So Christiana is involved in many different types of medical research as a clinician researcher. And tonight I particularly wanted to talk a little bit about why it's so important that patients get involved in medical research. Can't really do medical research without patients. There are great benefits to the researchers, but also to the patients themselves. And all of it helps speed up progress towards better treatments and a cure. So I'm very grateful to Christiana for giving up her time this evening. She joins us from a clinic room, I think, at the Central Middlesex Hospital. So Christiana, I'm going to hand over to you now to give us a talk, and do ask your questions through the chat as we go through, and we'll try and get to them as we can. So I'm going to hand over to Christiana now. Good evening, Christiana, and thank you for joining us.
Hi, Kathy. Thank you so much for that lovely introduction. And wow, there's it's around 87 people here. As Kathy says, I'm Christiana Dinah. I'm a consultant in medical retina, and I specialize in macular diseases and the research thereof. I'm going to give a talk today really about the importance of patients participating in clinical trials. But I think the current pandemic that we're in has helped me a lot, actually, because many of us probably, like I have, received my vaccine already. And I'm thankful, actually, to the 40,000 odd patients that volunteered to be a part of the Pfizer trial, which has enabled us all to now be able to look forward to getting a vaccine. And maybe this could be one of the big pivotal moments of this pandemic as we see our way out of it. And I think more than ever before, even non-scientists appreciate the importance of research and the impact on all our lives. So I'm just going to give a talk this time focusing on obviously the macula, but I think a lot of what's going on around us now is informing and hopefully helping to highlight the importance of research. So I'll just share some of my slides. I haven't got that many, I say, and then I have 20 something, but a lot of it is literally just going through things that we already know, but that I will be highlighting. So through the talk, I'll be talking about, I'll be looking to demonstrate the impact that clinical trials can have. As I mentioned already, we're starting to see that with the vaccines for COVID, but also then I'll go into the overview of the stages of clinical trials, the importance of patient involvement. Why does research take as long as it does? Because sometimes you hear about various new treatments coming along, and 5 years on, you're still hearing about it. You ask your doctors, and they're saying it's still being researched. And why does that happen? And the current progress we've made in wet macular degeneration and geographic atrophy. So the background, like I said, one of the big pivotal improvements that have been made in the last 20 years has been in wet macular degeneration. On average, we have over 26,000 new cases of wet macular degeneration occurring in the United Kingdom every year. The NICE approval of ranibizumab, otherwise known as Lucentis, in 2008, kicked off a significant change in the trajectory of wet macular degeneration in this country and indeed globally. So just as an example, just to demonstrate the impact, as of 2008, 6.9% of blindness was secondary to wet macular degeneration. This had reduced to 2.4% in 2011. So that's about a threefold reduction in approximately 3 years. To put it another way, in the United Kingdom, 225 people per million would be certified visually impaired as of 2005. And this number had decreased significantly to 137 by 2010. And obviously that's continued to decrease. So that's approximately 50% improvement in visual impairment just with the introduction of intravitreal Lucentis and Eylea. Similar numbers in the United States, similar in Denmark, about 50% reduction, similar in Australia, actually similar all across the world, all from the work that we've all collectively put in, both scientists and patients critically, to ensure that this treatment was brought from the lab into the clinic. So I put this up because I see this is essentially a slice of the whole world. So, this is a collective effort, but right at the core, right at the center is the patient. And this is why clinical trials are important. This is why we need them. We need clinical trials and research to help us understand the disease in question. We need it to help us develop new treatments. We need research and clinical trials to help us to understand how well a new treatment works and to compare it to existing treatments that we already have. Because it helps us also show where there are benefits to certain groups of patients compared to standard treatments. So we need trials and research to help us understand better and deliver improved quality of life and care to our patients. Now, what are the stages of clinical trials? After all the lab work is done in trying to understand how a disease occurs and how it impacts the tissues or the parts of the body, generally the next stage when trying to introduce a new treatment is called a phase 1 clinical trial. At that point, essentially 10, maybe 20 patients who tend to be healthy volunteers, so without disease, are invited to take part in a test of the treatment. And basically the goal at this point is safety. We just want to know, is it safe? And then secondarily, we want to know, does the treatment actually reach the targeted area? And does it remain there long enough to deliver the benefits? If that stage is successful, then we move on to phase 2. And in the phase 2 stage, normally you have more patients, 50 to 100, maybe 200 patients. And this time you're recruiting patients who have the disease that you're trying to study. And you want to see whether your treatment, which you now know is essentially safe from your phase 1, is whether it's effective in treating the condition. And also you're trying to determine what's the best dose that delivers the benefit you want with minimal side effects. If you're successful at this stage, you then move on to phase 3. And the phase 3 stage is more large scale, hundreds, maybe thousands of patients. And at this point, you're trying to demonstrate both safety and effectiveness on a large scale, confirm the best doses, and also compare to existing treatments to see if there's an advantage. For some treatments, you might then go on to phase 4, which is after the treatment has been licensed and is being used for patients. You want to then design studies that might tell you more about the long-term benefits and long-term side effects. Sometimes we also do observational trials where we're not actually testing any new treatments, but we're just observing the disease itself to see how it behaves, or where we're just actually trying to see the benefits or the effects of current treatments in patients over time. Nevertheless, at every single stage of clinical trials, the patient voice is really important and very much valued. Patients are, of course, a source of data, but it's much more than that. We really need patient involvement to even help us to ask the right questions, to help us determine what's the best outcome to actually try to measure. For instance, a recent survey of patients with diabetes suggested that when you ask patients, they felt that the clinical trials should focus more on the impact of the treatment on their quality of life and not on laboratory values. Importantly, as an eye specialist, I might say, I'm very focused on visual acuity. So how many letters you can actually read on the chart when you come to our clinic. However, as anyone who's been to an eye clinic would know, the charts we use, they're black and white with optimal lighting. Most people in a day-to-day environment are not necessarily walking around with perfect lighting, perfect contrast. And this is where the patient voice really has no competition. Patients can tell us how their quality of life is impacted by whatever treatments we're studying. They can tell us how the disease itself actually impacts their quality of life, so we know where to prioritize resources in terms of investigations. And indeed, it helps sort of channel the resources to the questions that matter to patients the most. In addition to this, patients can be involved in helping to spread the word about the results of trials or research, and also can be involved in sharing the experience of trial participation with clinicians and scientists. Because when you design a trial, it's important that you know that the experience of the trial itself to the patient was beneficial, and how you can actually improve the experience for future trials. So ultimately, the goal of research really is for it to be designed with patients, for the benefit of patients. And it's important for patients that you know that when we're doing research, because so I have a 6-year-old son, and he knows I'm a doctor, but he also knows that I do quite a lot of research. And his idea of research at this point, as a 6-year-old, is very much classroom, where they're telling them about mixing colors. So he thinks about it as an experiment. And whilst that's exciting, and yes, lab work and so on is all part of our part of research, when we're dealing with research participants, we have to also realize that safeguarding the rights, the safety and dignity and well-being of research participants is also at the forefront, not just of the scientists, but also of research ethics committees and NHS R&D departments. So anytime you hear about a research trial or a research project, it's important that you know that it's gone through various layers of committees and panels, including non-scientists and everyday patients who've looked to ensure that it's been designed to safeguard the rights of patients, their safety, their dignity, and their well-being. Sometimes as a researcher, I feel like 90% of my job is actually paperwork and signing things, but it's right that it is so, because we need to make sure that we do this safely whilst delivering the outcomes that patients would like us to do, and working with patients to do that. And when I'm talking about safeguarding, this includes the collection, the use and storage of any data that we collect from patients in the process of research. And by that, when I relate that to the Macular Clinic, it would include obviously your personal information, date of birth, name, and things like that. That's all dealt with very confidentially. But not just that it's confidential, it also means that anyone who is not a member of the research team cannot access it, even if they work in the hospital. That's how stringent the rules are around research. And then when you have outside sponsors like pharmaceutical companies partnering with us to deliver clinical trials, similarly, there's processes that they have to follow so that they only have access to what is required that pertains specifically to the research. So this is all very much done in a very stringent and strict way to ensure that the right respect is given to the data that's being collected and the information that patients are sharing with us. Now back to our progress in AMD. I mentioned earlier that we've come a very, very long way. 50% reduction on average in visual impairment globally with the introduction of anti-VEGF treatments. But there is still a long way to go, or at least there is some way to go. We would like to reduce the frequency of treatments, because after speaking to patients and with many qualitative surveys that we've done, we know that for a lot of patients, the significant burden of monthly, 6-weekly injections is significant on our patients. We know that there's still some subtypes of wet macular degeneration that do not respond well to the current treatments. We know that we need to find better ways to maximize hospital resources and utilize community resources to ensure early access to treatment and timely access to treatment. We know that geographic atrophy, which is the advanced dry macular degeneration, which is a slower progressing version of macular degeneration, has been difficult to treat because we really haven't had any therapy for it. And whilst we've come close with previous trials in the past, there still at the moment isn't any available treatment for patients with geographic atrophy. This geographic atrophy accounts for 1/4 of legal blindness in the United Kingdom. And given that significant impact, it is important that we start to aim for milestones in this condition as well. So some of our goals are to deliver approved treatments, the slow progression or reverse geographic atrophy, to understand the disease better, and to improve patient education. Because whilst we do not have current therapy, there is still a lot we can provide in terms of support to patients with geographic atrophy. So now I'm going to move on to updating on the current, more recent treatments that are likely to come to a clinic near you. So this is sort of like the, coming soon part of the trailer in the theater, so to speak. So first in line would be for wet AMD, the BOView. The recent phase 3 trials showed 50% of patients treated with BOView for wet macular degeneration were able to stay at 12 weekly intervals in clinic. And that's really important because that reduces the number of visits for these patients and their families, and also ensures that we're maximizing hospital resources whilst delivering optimal care. My understanding is that currently that's been appraised by NICE and it's looking good, and we should have a published NICE opinion on the 3rd of February or thereabouts. Next in line is faricimab, which is a different molecule. I'm very excited about this one because it looks like, certainly from the phase 2 trials, there is demonstration of efficacy up to 16 weeks, meaning patients having improved vision and dry macula up to about 16 weeks, which is 4 months. It's an interesting molecule because unlike Lucentis and Eylea, which act on just the anti-VEGF pathway, it acts on another pathway as well, the angiopoietin 2. So it's sort of double-pronged, and possibly might explain why it will likely deliver longer duration. The phase 3 trials are ongoing, and we're hoping to hear the results of that within the next year. Next is the port delivery system. This is slightly different. This is more surgical, and it's basically where a permanent refillable implant is implanted sort of right between the, in the sclera where you would normally inject a patient. But this time you can refill the ports that you've implanted with ranibizumab on a 6-monthly basis. Generally, this is reserved for patients who've responded well to anti-VEGF injection. In the trials, they included only patients who'd had at least 5 injections. Then they put in the implant and they injected the Lucentis every 6 months. And in the patients who got that versus the patients who were having regular Lucentis injections, they were able to, 98% of them didn't need any more than the 6 monthly refills. So that's actually significant because it would mean that potentially if this were to come to the clinic, patients could have their monthly injections for a while, which is like a run-in, and then have their implant and just have refills every 6 months. That trial is still ongoing, but the early results are encouraging. Then much further down the line is gene therapy, because when I say down the line, that's in phase 2 trials. And basically that's where there's surgical operation is done, and then you inject a gene that encodes anti-VEGF under the retina to then help secrete anti-VEGF, essentially, to help control the macular degeneration, the wet exudation. The phase 2 trials are ongoing, and the results are also promising that these patients might not need to have any treatment. This might be a one-off thing, or at least for more than a year, they didn't need treatment. So we'll have to watch and wait and see how that goes. But that's actually a promising development as well, but more early stage. Then, I'm not sure why this isn't, sorry. Moving on from there, we've got focusing on early access and monitoring. There's a couple of trials that are homegrown, funded by the NIHR. The FINEST trial is looking at monitoring of wet macular degeneration patients in the community by trained optometrists. And the idea behind this is if patients don't need to come to hospital, you could and they could be monitored safely at their trained local optometrists in the community, then you might actually have, that might be easier to manage and also help improve access to hospital resources for those who absolutely have to come in when they're reactivated. At the moment, that trial is ongoing, but that's also promising because it would mean that we'll be able to access all the expertise, both in the community and in the hospital environment, to deliver the best care for patients with wet macular degeneration. The Hermes trial is another trial that hasn't started yet, but is due to start soon. And that is looking at remote diagnosis, or rather referral refinement. So making sure that referrals from optometrists into the hospital are vetted remotely, so that those who need to come in are picked and chosen to come in, whilst those who can be monitored remotely in the community are managed that way. Whilst, and also within the same trial, they're looking to see whether artificial intelligence can actually accurately diagnose wet macular degeneration, as has been suggested in some early studies. So this is really exciting because this is now trying to use teleophthalmology and the new technology, artificial intelligence, to try to improve the speed and accuracy of diagnosis of patients with wet macular degeneration, because we know that the earlier you diagnose patients and the more accurately you do so, the better access we have to treatment, and the more likely you are to maintain vision. Now, I've put this excitement cartoon up there because this is how excited I am about geographic atrophy. As I mentioned earlier, there's a lot that has happened with wet macular degeneration, and it's exciting that there's even more ongoing. But for the first time in a long time, there's actually multiple options for geographic atrophy. Whilst none are in the clinic yet, we're super close this time. So I'm just going to list 3 intravitreal injections that are currently undergoing or about to undergo phase 3 clinical trials, and then a surgical option as well. The first one is APL2, otherwise known as pegatostoplan, long name, but essentially this drug, this is an intravitreal injection, much like you have for wet macular degeneration. But this time, this is for geographic atrophy, which, remember I said, is the dry advanced macular degeneration. And the idea behind the evidence around this drug from the phase 2 trial is that in patients who had monthly injections, we were able to slow down the progression of geographic atrophy by up to 30%. And this is now in phase 3 trials. My unit is participating in this, and we are probably a few months away from, well, 1 or 2 months away from the 1-year results being announced. And then we would expect the final result. Zimura is a similar intravitreal injection, slightly different target, but essentially it is also looking at delivering injections monthly or bi-monthly into patients with geographic atrophy, and has similar efficacy results. So slowing progression by up to about 30% at 1 year. Brimonidine is a different injection, this time delivered 3 monthly, and this was shown to slow progression by 10%, which is not as good as the 30%, but that trial is probably going to be refined for the phase 3. And again, it's a promising treatment because that's less injections. Let's see what the phase 3 shows. Then there's also gene therapy, just as I mentioned, for wet macular degeneration. And this picture is just basically showing you roughly a schematic of what that involves. And essentially, we would be looking at doing a vitrectomy, which is where you remove the jelly of the back of the eye and you inject some gene therapy under the retina. And then the virus delivers DNA into the retinal cells, which helps to make a protein that stops the immune system from attacking the retinal cells, keeping the macula healthy. Now, you might say, well, you've heard this all before, because I remember I gave a talk, I think in 2018 at the patient conference, and I'd mentioned some of these drugs, and we're 3 years on almost. So you might say, well, why does it take so long? Why does all of this take so long? Well, one of the reasons is the multi-phases, as I've mentioned, from the lab to finally the treatment getting to patients. And all these phases are there to help ensure safety and efficacy. But it's not just that. There's also the natural history of the disease. For something like geographic atrophy, for instance, it's slowly progressing. So to demonstrate that a treatment works versus nothing, you actually have to give the disease enough time to have made progress. And then you can say, well, this is what the natural history would have been. And this is now what the new treatment that we've done has done to change the natural progression or the natural line that this disease would have followed. There's also recruitment. It's important that when we're doing clinical trials, because they're designed, one, to be safe and to answer specific questions, that we recruit the right patients into the right trials. So by that, I mean, we need to make sure the patients that might have side effects of particular treatment are not recruited into that trial. We need to make sure that patients who will most likely benefit from a particular treatment are included. We need to make sure that factors that may confuse the clarity of the results are excluded from the trial. We need to make sure that we recruit patients that are more likely to stick to the entire duration of the study. And in addition to that, all these trials and all the data need to go through the necessary approvals. So that's why it takes a little longer. And sometimes, when you start a phase 1, I've just went nicely from phase 1 to phase 4. And yes, it's lovely when that happens, but oftentimes, and as is often the case, a drug might do well in phase 1 and phase 2 and then not meet its endpoint or the outcome that you designed for phase 3. And then, that gets shelved, or some tweaking needs to happen and then it needs to start again. So oftentimes that adds to the timeline from bench to the clinic. Now, what is the benefit to you, the patient, of participating in clinical trials? Well, there's the benefit of contributing to the advancement of science. I'm sure most of the patients or the people that volunteered for the Pfizer vaccine must really feel that acceleration of contributing potentially to the ending of a pandemic. There's also evidence that patients who participate in clinical trials or research have better general health outcome in general. And you might say, is that some sort of psychological effect? Possibly. But also there's the fact that when you come into it, when you're part of a clinical trial or research, oftentimes regular tests are done more than they would have been done when you're seen for a specific condition, because we need to check various tests, such as, say, blood tests. And for instance, when you come for a macular trial, you would normally have multiple images and blood tests and urine tests and so on, just to ensure that the treatment is not impacting on any other aspects of the body. But it also means that obviously if any derangements are noted, then this can be flagged up and treated early. So in general, patients who are treated in units where there's a lot of research, or even who participate in research, tend to have better general health outcomes in general. There's also the fact that you get to access new treatments before they're licensed or NICE approved. There's also the additional benefit of high quality free healthcare from leading experts. Now in the UK, we all benefit from free healthcare, but when you're part of a clinical trial, generally because of the length and because of the amount of data that has to be collected, the clinics tend to be smaller. You tend to have a dedicated team. I was going to show you a video of one of my patients where she talked about how being part of trials here, the trials unit here, is like being part of a family, because she sees the same research coordinator all the time. She knows my daughter's name and her birthday and things like that, because I see her every single month, as does the team. So there is that level of camaraderie that comes with coming constantly throughout a trial, particularly macular disease trials that tend to last for a year or two. In general, we find that patients who participate in clinical trial also benefit from general improvement in their own well-being and quality of life as well. You also have ready access to the team to ask questions whilst of course, all patients do, but in a normal busy clinic, it's not as easy to give the same dedicated time as you would in a trials setting. I wanted to highlight the Be Part of Research website, which I believe has also been integrated into the NHS app. Because a lot of patients say, well, you talk about research and I'd love to be a part of research, but I don't even know where to get started, or my unit, my local unit doesn't have, doesn't participate in research. Well, Be Part of Research is a website set up by the NIHR, which aims for patients to be able to, you can basically put in your condition and it will say what trials are going on across the country and in which units. And the idea behind integrating it into the NHS app is so every patient in the country who is interested can actually access the research trials that are on the NIHR portfolio, NIHR being the National Institute of Health Research, and find where research is going on that pertains to them, and then they can contact the team and see if there's anything available for them to be involved in. So in summary, I'd like to say that we're all in this together. It is a collective effort. But when I think about Lucentis, when I think about ELIA, when I think about the COVID vaccines, the Pfizer, the Moderna, the Oxford vaccines, really, I know that patients are right there at the core of it. And I hope that this talk has given you a flavor, one of your importance when it comes to clinical trials and research. We can't do it without you. We don't want to do it without you. We would like to do it with you at every stage, but also that ultimately, when you participate in trials, there's a lot in it for you, both from a well-being perspective and also from a outcome perspective in terms of general health as well. And that's the end of my talk. I'll be taking questions. Thank you.
Christiana, thank you very much indeed. That's absolutely terrific. Thank you so much. Right, we do indeed have some questions. So, I mean, the first question that has come up quite quickly is about COVID and what impact that has had on research. We know that of the research that we fund, a lot of it, in fact, all but one, I think, of the studies that we were funding at the beginning of the year had to stop. What effect has it had, do you think, on the research community as a whole?
Thank you. Thanks for that, Kathy. So I sit on the NIHR ophthalmology group for the national specialty group, and I have to say it has had a significantly negative impact, as would be expected. I believe at one point, up to 80% of ophthalmology trials across the country were stopped or paused. And that was in the first lockdown. And now, as of November, about 65% were back up and running. But with the new pandemic, or rather with the new wave, it's likely that some would have been paused again. We have the national meeting in a week, so I'll have the updates concerning this December, January period, but it has been difficult. One of the things we've done though is we created a video in the Northwest London area, which has been used, I believe, across the country to encourage patients to still come in where the research is still ongoing for their trials, and explained the measures we've taken to ensure that they can do this safely. The thing with trials is oftentimes when you're allowed to, we can actually afford to send taxis for patients to bring them in so they don't have to be on public transport. We can ensure that they only are exposed to 1 or 2 members of the team. You know, things are more streamlined than in a normal NHS service. However, in the first peak, a lot of the research team were actually seconded onto ICU or somewhere else to help. So even with the best of intentions, it just wasn't possible. What we did do though, was try to, when we had the summer lull, try to sort of create a COVID secure pathway for ongoing research, so that even as we predicted, people might have to be redeployed, at least there might be 1 or 2 members of the research team left to actually help keep things ticking over. Luckily, one of the things that's been prioritized is wet macular degeneration. So patients in wet macular degeneration trials were never stopped. throughout the pandemic. However, things like diabetic macular edema, geographic atrophy, which are slowly progressing conditions, rightfully had to be paused in some places because of the pandemic. So yes, it has had a significant impact, but I think we're getting back on our feet now.
Well, that's really good news. A question about the international nature of trials. So many of these big trials now are done across the world, aren't they? Are the ones that you are involved in, are they purely UK based or are they international?
So we're involved in international ones. We currently have 9 trials ongoing, and so for example, I'll mention the macular degeneration ones. The Derby study, the APL2 study, which, as I say, I'm literally jumping like a rabbit about, is international. We were the top site in the UK to recruit into that, and we feel very hopeful that the results will be positive, which would mean that for the first year results anyway, but it's a 2-year study. So by 2022, we should have the 2-year data, which will then facilitate submission to the to NICE. However, what we're doing alongside that is my team and I, including David Crabb and a few others, are working on actually surveying patients to see how acceptable injections are to patients with geographic atrophy. Because you remember, most patients with geographic atrophy have not had injections before, they haven't had treatments. We can't assume that, of course, yes, they'd love to have injections in their eyes. We don't know that. So we thought we would design a study that actually investigates the patient's voice and patient's perspective with regards to intravitreal injections for geographic atrophy. So if anyone's interested in taking part in that, that's just been submitted to ethics. We're interested to have you.
That's very interesting. So yes, just to remind everybody that is a treatment that's coming down the line now for dry macular degeneration, the first one that we think is going to reach the clinic. We know, though, that clinics are absolutely overwhelmed with demand for intravitreal injections for wet AMD.
Yes.
How would clinics cope if all the dry AMD patients can come along for injections as well? How would you cope?
When I mentioned this drug to my colleagues who are not even medical retina people, they were like, no, how is that even possible? But I think honestly what's going to have to happen is it will be analyzed in terms of who will benefit the most within the geographic atrophy population. Not everyone will, which is what I was saying earlier about criteria. We have to pick patients who we know the treatment will work on, but at some point there will have to be an expansion of services, because the truth is, if we have a treatment that works, we have to make it work. It will mean we'll have to redesign services. It might mean having to think about, like I said earlier, with wet AMD, the community, optometrists. We just have to think out of the box. But for me, right now, the main thing is let's get a treatment that works. If it works, we will then have to put our heads together to design a way to deliver it to the patients.
Are these trials, somebody's asked about whether trials are available in Northern Ireland, and somebody else has asked about when BioView, this new drug for wet AMD that lasts a bit longer, when did they get, I mean, really it should be pretty simultaneous with the rest of Great Britain and the British Isles, shouldn't it, in Northern Ireland? There should be no reason why these things would come along later in different parts of the... No,
I believe, it will be the same. I believe even in devolved nations, because when we do the ophthalmology specialty group meetings, there's representation from Northern Ireland, Wales, Scotland, and so on. So I would expect, typically what happens is if NICE gives it a favorable approval, you have about 90 days to implement it. And some places might implement it towards the end of the 90 days. Some places might implement it 10 days into it, whatever, but within 90 days or so, it should become available. But you would have to discuss with your clinician, because there will be, every new drug has side effect profiles and so on. So it might be suitable for you or it might not be. So this is something that will need to be discussed, but at least being available on by NICE or being approved by NICE means it then is free on the NHS. And then you can have the discussion with your clinician about whether it's suitable for your disease.
Okay, and we know that Belfast is a very active centre, very large, Queen's Medical Centre.
Absolutely.
Very large centre for medical research and takes part in many of these international trials.
And some of the lead experts are there. Tunde Pito, Usha Chakravarti was there. So, absolutely, if anything's available, it'll be available there.
Yes, absolutely. Okay, that's absolutely terrific. So a question here. A couple of people have raised the question of a new um, uh, test for early AMD called the DARC test, the DARC test. Can you tell us a little bit about that? I mean, one of the questions is, I think it's a test that's designed to pick up AMD when it's very early. And one question is, you can't treat AMD when it's very early. The NICE won't let you treat anybody, will they, until you've actually got a reasonably significant, actually, part of sight loss. So what's the point of this DARC test? What's it for, and what possible use could it be?
So one of the things I used to wonder when I was training in research was exactly that. My mentor would come up with research questions that I couldn't see the translation clinically. And I'd be like, why are we doing this? Yeah, we can write all these questions, we can write all this, but what's the point? DARC at the moment, as you've mentioned, is technology. I mean, the spearhead really is Francesca Cordero, and she initially started or worked on this in glaucoma. And basically what it does is it highlights which cells are about to go into what we call apoptosis, which is like self-death. So then you can translate that to wet macular degeneration as well, and it might be able to pinpoint early macular degeneration when, even before clinically significant disease. The idea behind introducing this in wet macular degeneration really is about understanding the disease. It's about understanding at what point, because at the moment, we don't know, there's still a lot of black spots in our knowledge about how the disease progresses. Right now, you're right, on NICE, I actually had a patient today who's got bilateral wet macular degeneration. One eye I could treat, just 0.3, the other eye is 6.6, and she's an artist. And she literally begged me, just treat this eye. I'm like, I'm totally tired. I can't treat this. And the reason is because sometimes when it's early, from NICE's perspective, you can get very slow progression, particularly with occult, which is a different type of wet macular degeneration, so that it could take a year or two before it becomes significant. And in that time, you could be having treatment constantly. So there's a cost risk benefit ratio there, but also there's the risk of infection like endophthalmitis and things like that in someone whose vision is actually not significantly impacted. So it's the same with DARC. DARC isn't really to help us pick up disease that we would start treating. It's more to help us understand exactly when it starts, how the cells behave, ultimately to help us design better treatments for the disease.
That's really interesting. So mainly used now for, at the moment, only really perceived as being used for research. It's not something that's going to be available for people for test. And I think there's some gene testing that's at the same stage, isn't it? Used only really in research and not for identifying patients. Okay, so a couple of other questions have come in. So one person here is 52 and he's been potentially diagnosed with macular degeneration. We normally think of AMD as being 55 or over, don't we? Would this person therefore be disqualified from clinical trials because he'd be too young?
Well, that's a good question. So generally, the strict definition is over 50. A lot of the trials will say 55 or 60 because we want to make sure you're not including people who actually don't have macular degeneration. Like I said, with criteria, it's about making sure you are testing the drug in the right population. Some trials, though, will include people over 50. For instance, any trial looking at the progression of early macular degeneration, for instance, will probably include him. But is he talking about being diagnosed with wet macular degeneration or just the dry drusen type?
I don't know. It's just AMD.
Dry, yeah. So I think he said dry. So that's not unusual to have drusen in someone who's over 50. And typically, if we were doing any trials, which would be observational at this stage, yes, we would include somebody over 50 because people over 50 have drusen. So that's not a problem.
A couple of people have asked whether any of these treatments that we've been talking about AMD today, but there's a great unmet patient need in the patients who have myopic maculopathy, and yes. Some of the anti-VEGFs have been used, haven't they? Lucentis and Eylea are sometimes used, not infrequently used in myopic maculopathy. What research is going on in myopic maculopathy, and these new treatments that are coming along? Is it possible that they could work for myopic disease as well?
Absolutely, yes, because with myopic disease has a spectrum, but if we're talking about myopic CNV, so where you have choroidal neovascularization, you're right that we use Lucentis and we use Eylea for that.
And that's essentially what's happening in wet macular degeneration as well.
Exactly.
New blood vessels.
Exactly. And these same new blood vessels happen in people who are very short-sighted, and oftentimes, I mean, for a slightly different reason, but the end result is the same. And these treatments work for them, and in fact, they work probably better in myopic CNV than they do in macular degeneration, because oftentimes our patients with myopic CNV don't need as many injections as our ones with macular degeneration. So I would expect that the next step would be that these drugs would also be trialed in myopic CNV. Because what tends to happen is, first, the drugs are tested in the largest population, because this trials cost billions, so it makes sense to go with the disease with the largest prevalence. And then after that, they'll design a trial for patients with myopic CNV. Oftentimes, though, doctors start to use them off license for myopic CNV. That's what was happening with Lucentis, Eylea, and that's what I would expect with now. Both Lucentis and Eylea did have trials designed for myopic CNV, and based on that, they were presented to NICE, and NICE provided a license for myopic CNV. So I would expect that these other drugs would do exactly the same.
They're just always a little bit behind, because it's a smaller population.
Absolutely, exactly.
Just going back to some related AMD issues, what would, in somebody who'd had active wet macular disease, for example, and been treated for it, perhaps may not need treatment for a long time, and then suddenly it activates. What would cause that to happen? The reactivation of a disease that's described as quiescent is the term, isn't it? That's used.
Yes. Yes. I think we have to remember that when we treat choroidal neovascularization, so the abnormal blood vessels that grows, when we treat it with anti-VEGF, we're not getting rid of the root cause. We are literally, I like to describe it to my patients as, we're not turning off the tap, we are plugging it. And when the plug melts away, the tap is still on, so you still get the leak. So oftentimes that's what happens until the environment changes, and we're not changing the environment with these injections. We're just basically plugging the gap. We're blocking some molecules, and then when that changes, the reactivation will happen again. In some patients, you're lucky enough where you treat them until quiescence, then they're quiet for 1.5 years or 2, then they reactivate. In some patients, it's longer, and the reasons why some people respond really quickly and then are quiescent for a longer time, and some need more injections more frequently and take longer, is still under investigation. And that's what I was referring to when I mentioned about phase 4 trials. And a lot of the studies or research that clinicians are doing is, yes, now we have these drugs for wet macular degeneration, but how can we better refine which patient needs what? Which patient, for instance, should be monitored every month? Which one specifically should be monitored every 6 months? And so on. We don't really know that yet. We're looking at work around biomarkers, blood tests, gene, like the patient's phenotype, genotype, things like that, but we don't know that yet. So different patients will respond in different ways, but ultimately you have to think of these drugs as pluggers and not turning the tap on.
Yes. Okay. Right. That's really helpful. Just very quickly going back to myopic maculopathy, you mentioned specifically the choroidal neovascularization, so the new blood vessels form. That doesn't happen in everybody with myopic.
No, it does not.
So it does the same parallel happen with the treatments that are coming on for dry macular degeneration. Are they also likely to be useful in dry, for the want of a better term, myopic macular degeneration? In other words, are they comparable kind of conditions in that sense?
So that is possible, but still to be investigated. So the drugs that we've got right now for geographic atrophy, so this advanced dry macular degeneration, right now are being used and tested in people with what we call native geographic atrophy. It started as drusen and has worked its way into geographic atrophy. Now, at some point soon, they will be tested in patients who have wet macular degeneration, but also have patches of geographic atrophy within it. So they're not native. That's more of a mixed bag. Patients with myopic CNV also have what we call chorioretinal atrophy, which looks like geographic atrophy, but the pathophysiology or how it comes about is different. So these drugs have not been tested in that, but that would be an area of investigation, but we're not there yet.
Okay, thank you. So a couple of lifestyle questions have come in. What is the impact? We know that smoking is very closely linked to macular degeneration. Smoking is very bad for your eyes. What's the impact on somebody who's got the disease if they're smoking?
Okay, so a smoker versus a non-smoker, a smoker has a 2 to 4-fold increased risk of developing macular degeneration, and a 2 to 4-fold increased risk of developing choroidal neovascularization. So we know that from the large population studies. The ones who are smokers tend to develop advanced macular degeneration 2 to 4 times more than those who don't. Now, if you're already a smoker, so your question is, if you're already a smoker and you already have macular degeneration, are you likely to do worse? Yes, is a simple answer. Yes, because smoking basically deprives your eye of, basically gives your eye oxidative stress. And that's what contributes to the degenerative process in the first place.
So it's very bad. Don't smoke. Don't smoke.
Yeah.
Very quick one. We're getting to the end of our time. So briefly, just touch, if you would, on supplements. So this is the other end of the spectrum. Can you make yourself healthier by eating dietary supplements in addition, well, let's say, to a good, or instead of a good diet? So
large trials like the AREDS2 suggest that yes, you can, but many people would say, so the experts are divided. Everyone knows that supplements, the MacuShield Gold, the ones that use the AREDS2 formula, certainly don't do you any harm, right? And the idea is that in people with moderate dry macular degeneration, so that's not mild, but the moderate type, it reduced the progression to the advanced stage of macular degeneration. However, others would say a balanced diet rich in antioxidants like spinach, kale, the green vegetables would do the same. What I would say is, if you look at what you're eating, and particularly if a lot of it is processed, cooked, because with vegetable, fresh is better than cooked and so on, because you lose the nutrients, then you do yourself no harm by taking the supplements. However, if you feel, and I've met patients who actually honestly have what they describe to me as,
oops, Christiana has
I have to say I don't manage that myself, then yes, you don't need to take them.
Okay, that's really helpful. Very quickly, a question about 2 other forms of treatment, which I don't think are really largely used. The first is laser treatment for macular disease, and the second is surgery. So there used to be talked about something that I think was called macular translocation or something, wasn't it? Which was moving the retina slightly to try to reposition a healthy bit of retina. So laser, we don't hear about laser or macular translocation nowadays for macular disease, do we really?
Yeah, because there's just more promising things. The more recently, there's been various lasers trialed and the results were poor. In terms of macular translocation, I think they were doing macular translocation, they were doing RPE translocation, all sorts of things. I think Lyndon de Cruz, I don't want to 100% say for sure, but I think he's still refining that technique potentially. But that's not what's on the forefront at the moment. Right now, for wet macular degeneration, the exciting things, the close things, are the new longer acting agents, and there's quite a few of them. I mentioned a couple, but there's a few others that we're trialing as well, all looking at 12, 16 weekly. There is the port delivery system, which I think is going to be a game changer as well for those patients where it's suitable. and there's gene therapy, which is a long way away, but looks like if it works, when things are refined, will definitely be make a significant change in a group of patients as well. That's for wet. And then for dry, we have the new treatments. There's at least 3 of them that are injections, and we're studying to see whether patients will even find injections acceptable. Then there's the potential of gene therapy for dry as well. There's a few other things, like a few tablets that are being trialed, but those are more early stage.
And just to be clear, that none of these treatments that are coming down the line are about restoring vision, are they? They're all about slowing progression or halting progression. It's not really about restoring lost vision. We're not quite there yet.
We're not there yet. I think that everyone would say that's the goal, absolutely, but we're not there yet. At this point, we're very, very close. Probably a hairbreadth away from being able to say we confidently have a treatment that can slow progression. And that's the furthest we've been. So that's really good. But yes, the goal must be long-term to reverse damage.
And we need more research, and we need more researchers, and we need more patients to take part in research to speed us down that track. Christiana, we've run out of time, but thank you so much for such an interesting talk. I'm sorry if we didn't get to your question. I've tried to get through as many as we possibly could. I think we got to pretty much all of them. But I'm so grateful to you. Thank you very, very much indeed for such an interesting hour in your company. It's absolutely lovely. Thank you so much. And let me tell you that next month, our guest will come from Southampton. His name is Alistair Warwick, and he is going to be talking about the genetics of AMD. We understand more and more now about the genetic causes and the risks that lie behind macular degeneration. So he's going to be talking about all the latest things that we know about the genetics of AMD. So that will be on Tuesday, the 16th of February. If you want to join that, you'll be able to find the link on our website, on the virtual clinics page of our new refurbished website. So go and have a look at that. And it's very easy to join through that link. Thank you to everybody for joining us this evening. Thank you for all your questions. And thank you, Christiana, again.
Thank you so much, Kathy. And thanks for everyone that came. That's amazing.
Thank you, everybody, and good night.
Good night.